Hello and welcome everybody to our SBC for Service Delivery meeting. We're so glad to have all of you joining us today. I know some of you are not regular members of our SBC for Service Delivery group, and so I just wanted to give a quick overview as we begin about our community of practice. This community of practice we are a group of practitioners and donors who are working to improve the practice of SBC, of integrating SBC into service delivery settings. Today our topic is using SBC for service delivery and outbreak settings specifically. Many in our group are focused on RMNCH programming, and so that will be the focus of our meeting after we go through some of our lessons learned. And just to introduce myself, I am Heather Hancock, and I'm a Senior Program Officer working at Breakthrough Action. And our community of practice is hosted by E2A and Breakthrough Action. So welcome everybody to our meeting. We'll go ahead and get started. Our first activity is that we just want to get everyone starting to introduce ourselves. We don't have time for everybody to go through and introduce themselves given the number of people that will be joining today, but we're going to be using Poll Everywhere today. I don't know if you're familiar with it, but all you have to do is use your browser. You can either go on your phone or on your computer. The URL is there, pollev.com/JHCCP. And when you go to that URL, you will see a map there, and all you need to do is just click on the map to show us where you are right now in the world. So we'll just take a couple of minutes to do those introductions as more people are coming into the room. Okay, I can see already that we're starting to see people across the United States and Canada. Do we have anybody in Europe or Africa? There we are. Great, so I see that we have a pretty nice spread. It's nice to see, especially as we're all working from home, that we really are in several different places and we're all getting used to this. So we'll stop this question for now and start our presentations. Okay, so just to give a quick run through of our agenda for today, as I mentioned, we recognize that many of our community of practice members are focused on implementing their RMNCH programs. And of course, COVID-19 has had a big influence on the way that we implement our programs. And so today we want to talk through some of our lessons learned from past outbreaks. And so we'll start out by showing some models and best practices for using SBC for service delivery and outbreak settings. And then we'll have some presentations that focus on learning from those lessons in the past. And then we'll have some moving forward presentations. So what do we do now with the COVID-19 outbreak? How can we use SBC for service delivery in those settings? And then we'll have a discussion portion where we talk about really the implications for our programs right now beyond just COVID-19, but how do we continue to implement our programs and get services to people who really need them? And so we will start out today, with a presentation by Claudia Vondrasek, who is the Director of Programs and Integration for Breakthrough Action. So Claudia, go ahead and you can start presenting.
Great, thanks so much, Heather, and good morning to everybody. Let me just pull up my notes. All right, so welcome everyone to this critical discussion about how we use SBC, or in the case of my presentation, SBCC, to help clients, their families, and communities, and providers navigate in emergencies such as our current COVID-19 pandemic. So slide. You all know by now, or I hope most of you know by now, the circle of care. So my first question, and feel free to put responses in the chat, what are the important points of intersection between households and the health system? Any suggestions? Not seeing any suggestions in the chat just yet. So maybe what we can do is we can start by looking closely at client-provider interaction, and that's in that green section over on the bottom right. And the core of that interaction is trust. And that trust has been built up since before the client arrived at the consultation. It starts with the relationships that are established in the community, and it's affected by the attitudes that households maintain about health services. And as you all know, sometimes those attitudes are favorable and sometimes those attitudes are less than favorable. And so our job, especially during this time, is to kind of take a closer look at the attitudes that prevail, but also then that interaction between communities, families, and the health system. Next slide. So there's another question for you. What are the most important standards or norms of quality service delivery according to clients? So we'll go to the next slide. And you'll see that this is information that's been collected from across West and Central Africa, but most often the client's top priorities include cleanliness, prompt providers, a warm, caring attitude, technical knowledge of RMNCH, and solutions to the problems that brought clients into the health center in the first place. So next. All right. Sorry if there's a chat. I'm moving on. So during the Ebola epidemic in the Mano River region, and in Guinea in particular, the health infrastructure, I'm mentioning Guinea because that's where I work, the health infrastructure failed to respond to the needs of the population. And so the big question was, would people come back to the facilities after the epidemic? And what we know is at the end of the Ebola epidemic in Guinea, 63% of health workers believe that community members were still concerned about infection prevention in the health centers, and that served as an obstacle. So visible infection prevention practices and facilitated trust building between clients and providers were key for increasing the use of those health services. And the kind of facilitated trust building there were community dialogues that were established, and that was really a terrific opportunity for people to come together and be able to talk about what those things were that either, you know, were obstacles to people using services or that they were concerned about. And it was interesting because through those community dialogues, the community members learned about the challenges that the health system had to be able to offer quality health services. So that was a terrific opportunity. In Guinea, there were also clinic makeovers and a really strong community involvement in those makeovers. And the dialogues and the makeovers really responded to what the community set as their priorities. So next slide. This is the helix that we developed as a result of all that wonderful experience in the Mano River region. And it's actually, it's exciting to kind of come back to it. I have to admit that when Heather first asked if I would like to talk about this, I was like, oh yeah, the helix. It was such a really important reflection at the time of the end of the Ebola crisis. And, you know, here we are in another pandemic, and it is really timely for us to be able to think through this. So let me just talk a little bit about this diagram that you see there. So essentially, why a helix? We wanted to express this important relationship that I was just describing between the health system and the community as the two strands of a DNA double helix. The structure of the DNA ensures stability over long periods of time, but allows for adaptations in a changing environment, much the way that we respond to a crisis or an emergency or an epidemic. In the same way, the SBCC emergency helix, which is what is presented in this slide here, describes a communication or SBCC blueprint for strengthening community stability, health system adaptability, and the evolution towards resilience. That's what's written at the far right. So the foundational concept of this framework is the relationship between the health system and the communities. The need to work in unison is widely acknowledged. Yet, a different reality plays out in the context of an emergency, as you probably all know very well. The health system, which is used here to mean healthcare delivery system and the government bodies that are responsible for protecting and improving health, may prioritize clinical safe and effective measures at the expense of individual freedom during emergencies. We've heard so many stories about people being so frustrated that they can't get in to see their loved ones once they enter into the health system. So there's an example. Communities, used here to mean the general population, especially those who are not already part of the health system, are likely to interpret an emergency in a variety of ways and may prioritize their actions according to a belief system that is a traditional belief system or something just, conventional practices in the community. It becomes essential to bring those communities to appreciate the care offered by the health system. In pursuit of building resilience to health emergencies, the SBCC emergency helix presented here is best understood as a repetitive unit. So as you see, it's moving through this, the curve there, strengthening emergency communication with each cycle of emergency preparedness, response, recovery, and reconstructions, with the communities at the center of all of it. As you see in the diagram, excuse me, the underlying phases that you see there, pre-crisis, onset, response, recovery, and reconstruction, and that curve that you see there, that's taken from CDC's Crisis and Emergency Risk Communication Guidelines. And in fact, that curve is used by many working in this field. So let's go, Let's go to the next slide. And here's a closer look at the phases that are included in the helix. This document is available online, and we can certainly share the link in the chat. But just to take a quick look, you'll see those phases to the emergency on the far left. Pre-crisis, onset, that's where the cases are increasing. The response, this is where cases may be decreasing, but the health system resources may also be depleted and there may be fatigue, etc. Recovery, and then reconstruction. And then the steps to effective SBCC are preparedness, inquiry, so we know that we need to be able to develop some kind of understanding of what's happening in the community, some rapid formative research. We develop a nimble SBC strategy, we mobilize communities, and we engage with the media, and that's happening during that time of onset. In the next section, sustain, efforts need to be sustained. Even if we see that the cases are decreasing, we know that the efforts need to be sustained. I feel like we understand this so much better now with the present COVID-19 situation. And there is fatigue. And as the situation becomes a new normal, there needs to be the rumor tracking that we all know. We need to share new knowledge as it becomes available. And we need to address other health areas. And I think this is where we realized the challenges of the Ebola crisis is that malaria and childbirth were two areas where we saw that there were incredible increases in morbidity and mortality because people were not using the health system. So as the emergency spreads, often we need to think of new strategies. And what's really critical at this time are these feedback loops that are established with the communities. And then the recovery and reconstruction, we can see that the activities that I described a little while ago in Guinea were really important as well, because it really was a way to show the community very tangibly that as the community and the health systems came together and as the resources were provided, there were clinic rehab activities held, and so people could have renewed faith and satisfaction with the health system. So we're going to go next. So what's interesting is, as you can well imagine, underlying this whole process are these four principles: community-centered, rapid, systematic, and coordinated. I'm not going to go too much into detail because we want to get to the heart of the discussion here, but I did want to just to come back and underline the importance of this being community-centered. Communities are the central actors of a health system, and the health system depends on communities for cooperation. Community action is essential when medical interventions alone cannot stem the public health emergency, and this has definitely been demonstrated across the planet and with a number of these different emergencies. So SBC provides a mechanism for listening to the communities and mobilizing them to take swift action, as well as building resilience to deal with future emergencies. And this was made just so evident during the Ebola outbreak in the Mano River region in West Africa. So rapidity, I think that's self-explanatory, systematic, and then of course coordinated. I know that we're spending a lot of energy currently on being able to enhance coordination to be able to respond to these public health emergencies. So that is, oh, I have one more slide if I have the time. Heather, can you indulge me a minute? Essentially, I just wanted to be able to share this example from West Africa, from Guinea. This was a program that was expanded. The Gold Star program was expanded as the Ebola outbreak was brought under control. There was a lot of concern about the effects of the outbreak on clinic attendance, as I was mentioning. And this was a collective call to bring people back to clinics. And as confidence grew, people did come back, as evidenced by the statistic that's in the bottom, that there was a 17% increase in the clinic attendance over the 12 months after the outbreak was considered over, even though there were some flare-ups here and there. But this was measured in the areas that were most hard hit by the epidemic. So this is an interesting example that I think is worth considering. So I think that's the end of my remarks, and I'm happy to take questions after. Thanks.
Thank you so much, Claudia. If people have questions for Claudia, you are welcome to put those in the chat box, and Claudia can be responding, as Corey Fordham, who is a program officer on the Breakthrough Action Project, will be presenting about just a few lessons learned and best practices, and that will really frame the rest of our presentations for the day. So Corey, go ahead.
Everyone, it's a pleasure to be here. Next slide. I am going to give a quick overview on risk communication and cover some best practices. The WHO defines risk communication as the exchange of real-time information, advice, and opinions between experts and people facing threats to their health, economic, or social well-being. The purpose is to enable people at risk to take informed decisions to protect themselves and their loved ones. Next slide. So I don't know about you, but I am seeing the impact of emergencies on the emotional health of the people close to me. And we know that people have a range of reactions to health emergencies. And effective risk communication is aware of the many ways that its audience may be feeling and cuts through or plays on these emotions in a way that encourages positive action. Next slide. What we need to do, our effective risk communication also strikes a delicate balance of raising an audience's awareness of risk while also raising their perceived ability to prevent or reduce it. Next slide. NCCP recently recapped 5 lessons that it's learned from its risk communication and community engagement work. We think that these are important to keep in mind as you create SBC materials or implement service delivery activities in the COVID-19 context. And these lessons are woven into a lot of the presentations you'll hear today. So they're more big picture ideas to keep in mind as you listen to the other presentations. So the first lesson is to build trust. People need information from sources with expertise, and they need to hear them from trusted sources like public health experts and at regular intervals. If incorrect information is shared, experts need to correct the record quickly to ensure that trust is maintained. And when too much time passes in between communication, people tend to fill the void with inaccurate information from unreliable resources. So this is why it's important that we're really honest about what we know and what we don't know. Next slide. The next lesson is to have one set of messages. Spokespeople and influencers must be on the same page so that people know exactly what to do to protect themselves. Otherwise, people make up their own minds about how to behave, which may be against advised behaviors. Next slide. We also need to be thoughtful about countering myths and misinformation. Ignoring rumors and hoping that they dissipate on their own is a poor course of action, especially in a crisis. We need to create systems to dispel myths and correct the record by sharing the clear, accurate messages that experts have agreed on. And where possible, when correcting these myths or misinformation, it's important to not reinforce that myth or to restate it because we don't want to reinforce the myth. Next slide. It's important to promote action. Effective risk communication needs to balance raising awareness of risk with promoting the ability to act. If people feel like a problem is too big or that prevention behaviors are too hard, complicated, or confusing, they may feel overwhelmed or paralyzed. Giving them concrete things to do calms anxiety and promotes a restored sense of control. Alternatively, if doable actions are promoted, but people don't feel that they are at risk, they'll continue business as usual. Next slide. And then lastly, we need to be empathetic. Communication should be understanding and coordinated. The unknowns in a crisis like this can be scary, but helping people understand that they need to take action for the greater good can help foster community and have long-term positive benefits. Next slide. And so I just wanted to recap some of the messaging do's and don'ts. So we do want to provide simple, doable actions to reduce risk and also acknowledge emotions, fear, anxiety, sadness that people may be experiencing. We want to keep messages short and concise and limit to the most important. We want to state relevant information that the audience needs and wants to know, and we want to acknowledge uncertainty. Next slide. For don'ts, we don't want to fuel fear or anxiety or provide too much background information that can distract audiences. We don't want to develop long messages addressing more than one issue at once or deny uncertainty. And we don't want to speculate about issues related to the emergency or provide dishonest or factually incorrect information. Next slide. And then next slide. And that's it for the 5 lessons. And we just want to, and this slide is just a recap of some of the things that Claudia mentioned around informed, about understanding your audiences. So if possible, you may want to conduct a rapid assessment of community members' knowledge, attitudes, beliefs, perceptions. So, and also figure out who or what is their trusted source, and also conducting a stakeholder mapping at the national or community level can give you valuable information about who you can work with. And we encourage you to consider engaging with networks within the health sector, as well as outside. And where possible, review traditional and social media sources for misinformation or rumors. And thank you very much, and I'll be responding to questions in the chat box.
Thank you very much, Corey, for taking your time to give us that presentation and frame the rest of our presentations. As Corey mentioned, we will be having some presentations that dive more into a few of those concepts. So to start out our meeting today, we really wanted to talk about what kind of lessons can we learn from past outbreaks. And so we have a great variety of presenters here today to talk about some of those lessons and also how we can move forward. So to start today, We are pleased to have Melinda Frost from the World Health Organization here, and she will talk about some of the World Health Organization's work that they're doing currently with COVID-19 and in past outbreaks, and also the importance of building trust. So Melinda, over to you.
Hi, thanks for having me today. Oops, trying to get the lighting right here. I hope you're having a pretty day out there. I'm not sure. Well, we have 69. Who knows what it's like around the world. Anyway, thanks for having me today. I'll just kind of go through what we've been working on at WHO. A little bit different for this response, maybe compared to past responses. I enjoyed seeing your presentation, Corey, because I think I actually wrote a lot of the text that you had pulled out either from WHO or from CDC, both of which I've worked with in the past. And so now's my chance to actually implement kind of what I've been saying in trainings and various documents, and hope we're doing an okay job, but happy to hear your feedback. So I guess we can go to the next slide. Just gonna put on the light here. I think maybe if you've been paying a bit of attention, you probably heard from WHO that we've been doing this new concept called managing infodemics. And in fact, in our incident management system, the pillar of response that risk communications falls under is actually referred to as the managing infodemics pillar. And it's right alongside our health ops centers of infection prevention and control, clinical management, and so on. So it's, I think, receiving a much higher attention than maybe it ever had in past responses as well. Generally, you know, we're describing an infodemics as an excessive amount of information about the problem, where it becomes difficult for individuals to find the information and trusted information that they need in order to make decisions based on their health protection. Next slide, please. So one of the things that was launched right along with the COVID outbreak in the beginning of January, it wasn't called COVID back then, but we launched a concept idea that we had previous, actually just last fall even. It was called EPI-WiN, which stands for the WHO Information Network for Epidemics. And the idea here was that WHO would try to reach out to more defined audiences that we never really had tried to reach out specifically with before for targeted information. Initially, we knew we would always want to reach out to the health sector. Certainly, we saw quickly that we needed to reach out specifically to travel and tourism, faith organizations. We always wanted to reach out to employers and employees, food and agriculture, and so on, in an effort to streamline our information through trusted sources that could actually get to audiences and individuals more quickly than WHO traditional channels. So we started this right away, and we did it through a number of different ways, but primarily we've been running you know, teleconferences, webinars, even prior to when everybody else had to use a webinar to communicate specifically with these sectors. And as we've done this over the course of the pandemic, it's come out with some really interesting things for us. We've been able to directly work with health sectors and in different aspects, occupational health and so on, to develop information and guidance. And we're almost doing like live focus group testing on a global basis, and better able to churn out documents that are a bit more tailored for audiences. For a faith-based group, we did basically a live focus group on developing a faith-based guidance for practicing safely during COVID. So just some different things that we're trying to do to establish stronger ties and more specific information and two-way information networks with target audiences throughout COVID. But this will continue from this point on. In fact, we met with some of our faith-based colleagues, and they were like, they said to us, you know, WHO comes to us whenever there's an emergency. We want a long-term relationship. So we will definitely be continuing these networks post-COVID, which I hope is soon. But okay, next slide. This was the whole idea behind it. It's nothing new to you communicators out there. I think you would see how this would all work, but just the whole idea of an amplifier concept. And we've, this is just an example of how we've been able to partner with international labor organizations and so on, which is frankly right down the street from WHO, and be able to potentially reach a number of organizations, and then thusly millions of workers and hundreds of countries. So that's kind of how this has been working. We'll be able to give more metrics a little bit later on. Next slide, please. And this is just one example of how we've been working with the healthcare sector and the different topics we've been trying to target: healthcare worker safety, safe workplace, continually updating our clinical care guidance and infection prevention and control, and just reaching out to a number of different networks to, again, make sure that our information is getting to the individuals that need it, and is targeted for their specific information needs and tailored for their circumstances. So this is just the example on healthcare. Next slide, please. And so the thing that we've actually really been working towards now is better how to measure what an infodemic is. And you can see how important that is to our Director General, Dr. Tedros, and our UN organizational leads as well. It's becoming quite a hot topic. Next slide, please. So, the whole goal is just that individuals and communities can better protect themselves. I think actually Corey may have even said this, in understanding the collected knowledge and so on. So we're trying to just better ensure that people can, more easily access trusted sources of information. And WHO is now in more places than just on your Twitter and on your website. We're now reaching out to these different audiences in different ways. Next slide, please. There's no doubt that, the situation that we're faced today, even when community engagement is concerned, is that the whole concept of community has really changed, right? We're no longer, even just with the situation we're in, able to necessarily meet face to face. So just thinking about ways that we can pull communities together, even though we're at a distance under quarantine, and so measures. So it's just a new way for us to think, and all the more reason that we need to be reaching out to different audiences and networks in different ways. Next slide, please. I think these are statistics that you've probably seen from other places, but just, again, this is on the social media front, the number of tweets where COVID-19 was mentioned just in the month of March. And you can move on to the next slide. And so we're trying to better quantify what this means in terms of an infodemic, and how to pull down the curve of an infodemic with trusted information through several different ways. So we ran an ad hoc consultation a couple of weeks ago, where we had 21 presenters and a number of different ideas, close to 600 ideas submitted. And we're in the process of developing this framework that we're now working under, where you can see it's one of my colleagues came up with this ISAC: identify evidence, simplify knowledge, quantify or amplify the action, and quantify the impact. So this is sort of the rhythm that we're working in right now to better pull down the infodemic. Probably many of you may have even been involved, if not presented, in that ad hoc consultation a couple of weeks ago. And all the reports on that, the videos should be going up online, and our EPI-WiN website, which is who.int/EPI-WiN. Okay, and then next slide. Okay, just to highlight some of the faith-based, work that we've done with our different partners around the world to give better faith-based guidance. Since, we know that a number of outbreaks were occurring in faith settings. Maybe we'll move. I know I'm down to the end of my time, and I think there might be some interesting slides towards the end here. You can move on. This is. Next slide. Yeah, okay, so just some signals monitoring that we're doing to better feed into our response in terms of, we're beginning to measure more closely the sentiment, measuring the emotional response of audience members, and identifying the different narratives, rising narratives, and really trying to hone in on the science messaging that we can be giving. So an interesting division, well, not division, it's sort of a link within WHO that we've been focused on in risk comms, is that we're really, really focusing on the scientific messaging and how that can help inform through our more external communications channels, and how we can begin to shape the information just purely from a science point of view. We've had to very much divide our scientific messaging from our reputational risk messaging, but of course they all blend together when it comes to risk communications. And I think there's one last slide, maybe next slide. Yeah, and you can just see the taxonomy of how we're breaking out our signals monitoring, so we can better know which kind of communication we need to, what kind of messaging and risk communications we need to be using at the global level, and then at our different regional levels as well. If there's anything I've learned from this, it's sort of the challenge of communicating from WHO global, because in one sense, of course, with risk communications, you never want to think about the audience as being one person, but from the WHO very external channels, in a way, you really have to think about everybody globally, and give these messaging that gives messaging that kind of can sync with many different people. But just to let you know, the way it operates is that we have this sort of global view, but we work very closely with our risk comms and community engagement colleagues at our regional offices to then adapt and use. And just in terms of community engagement, we're working side by side with many partners, UNICEF and IFRC, and your organization as well, to make sure that our information can be more adaptable and resonate more at the community level. Okay, and I think there's one more slide, but I think, yeah, just the way that we're tracking sort of the information coming in. This is just one of the many data sources that we're using to drive our communication. This is, of course, more electronic channels. We also have another data source. We're getting more individual social science data in, and we also, of course, track what's going on at our regional level and get needs from there as well to help prioritize our weekly rhythm of science-based communication, risk communications response. I think that's pretty much all I had. I know it's pretty quick. You guys can look at that a little bit later, I think. Just different measurements. So some of the things that we're looking for in the future, an infodemics observatory. And as part of this, I think we're going to try to find trust drivers in public health messaging to help, again, on a national level or more community-based level, drive down mis and disinformation that we see primarily through digital sources. And maybe there's, yeah, just some more things that we have under development. Sorry, my camera's kind of in the way of this. Just to be able to better map trusted fact checkers, try to identify what types of misinformation we're able to track, and then have a repository of facts and a resource center for countries to be able to better track misinformation, disinformation, and then these elements here as well. Sorry, I know that was super quick. Did you want to do questions and answers?
Yes, that would be great. And thank you so much, Melinda. And I know some people have asked in the chat if these slides will be shared, and they will be shared afterwards. So anything Melinda wasn't able to cover completely now, you will be able to look at the slides. So we do have a few minutes for some questions for Melinda. I know that you've put a few in the chat box. On is asking, what can some of us do as informed citizens in our own community?
Okay. Well, I mean, what we're typically saying is that you're going to have a little motto, you know, you can be an infodemic fighter too. I mean, at least electronically, obviously, always get information from trusted sources, encourage other people to do so. If you're looking at different social media, of course, look at, you know, try to cite the reference, you know, don't share, things like that beyond that. And then I think just simply amplify the messages. Like anytime you're hearing misinformation or disinformation, correct it with, you know, the right, you know, the correct, most up-to-date information. I mean, I think if COVID has taught a huge amount, it was like a lifetime of risk communications lessons learned in 3 months. And yeah, I mean, one of the things is the science has changed so rapidly. I mean, it's just been astounding and very difficult to keep up with here. I mean, to give you any idea of how much the science is changing, I think right now, WHO, we're known for our guidance release. I think we have 110 documents in the queue to be published on different guidance around COVID-19, if that tells you the amount of information we are trying to churn around and translate to audiences. And then I think on a more community level, of course, how to implement these things and make it real and relevant for your community members.
Thank you so much. And Jacqueline is asking, she says, part of the challenge with risk communication in COVID-19 is around the symptoms, given that we continue to identify new ones and mostly around the absence of symptoms. How are we approaching this?
Yeah, that's another challenge that we're having. And I think for us, we're just continually trying to update as relevant. I mean, there's some basic symptoms that have just been consistent throughout. And while you're hearing a lot about new symptoms through the news and stuff, I think what we're really trying to do at WHO is to talk about the prevalence of those types of symptoms. Are we seeing a lot of that, or did you just hear it on one news report? And really kind of couch that for the population to know that maybe you've heard about this symptom or that symptom, but we still don't have the scientific evidence, or we haven't seen it in enough of the population. So I think it's constantly updating our messaging, which I wish I could say was coming out in many, many different formats simultaneously, like, globally, boom, one time, so that we are constantly in sync with each other. I don't think we're quite there yet. And I think our most updated messaging is happening in our press conferences, which happen on a nearly daily basis. But it's my goal to make it sync up more quickly and have a farther reach through our partners and through our regional and country offices and through different sources of information as well.
Great, thank you. And I think we have time for just one more question from Rachel. She asks, in the ISAC framework, could you please clarify why fake news would be published weekly?
I don't know if that maybe it's meant to address fake news. I don't see that. I have that slide up in front of me. Sorry, if you want to go back to that. I think it was a cartoon. Wait, next one, but there you go. Oh, look at that. Okay, this was obviously a cartoon done by the guy for our thing. This came out of the ad hoc consultation, so maybe it was one of the ideas that came up. We will not publish fake news weekly. We may address it weekly. What we're definitely doing is that we have a weekly rhythm when it comes to risk-comms priorities and strategy. So on a weekly basis, we are pulling in all of this data, like the later slides I showed you, again, the social science data that we're pulling in, and then feedback from all these mini sort of social science and media metrics, things that are occurring at our 6 regional offices. And we're pulling all of that together, and then it's like triangulating or quadrating and pulling it all together and coming up with the priorities that, of course, most affect the public's health on a global basis. And then are really focusing in on the science-based things that we can, messaging and the materials and so on, that we can develop to address those issues. Again, there's a whole reputational side of this too, with the global politics and so on. That definitely gets split off to our external. I've drawn the line clearly because really we have to divide and conquer these days. But so I don't know, apologies about what that slide says. I will say that we do have a weekly rhythm for risk-comms response. And yeah, I hope working well, but always happy to get feedback, except I'm sure I know what some of your feedback would be.
Thank you so much, Melinda. I know you have to drop off. I know there are a few more questions in the chat box. If you have a moment to respond to any of those in the chat box, that's great. If not, thank you so much for joining us.
Okay, you want me to just answer in the chat box? Okay, I can hang on.
Yeah.
Or try to. Okay.
Okay, thank you so much. Okay, so our next presentation will be by Ann Ballard Sarah. who's from the Knowledge Success Project at Johns Hopkins Center for Communication Programs. And she's going to be talking some about the importance of knowledge management in emergencies and outbreak settings, specifically drawing on their learning from Zika and the Zika Communication Network. So Anne, I will turn over to you.
All right, hi everyone, thank you. I've turned on my video to say hi. I'm Anne Ballard-Serra, and as was mentioned, I work on the Knowledge Success Project at the Johns Hopkins Center for Communication Programs. And we're a newer project. We're a 5-year USAID knowledge management project with a mandate to help family planning and reproductive health professionals find, share, and use essential knowledge. And today I'll be sharing our recommendations for knowledge management in emergencies, primarily leveraging our work from the USAID Zika response that we conducted under the K4Health project. So on the next slide, we'll get started. So you'll see that during the USAID Zika response, over 20 implementing partners were active in 22 countries over a 4-year period. So as you can imagine, there were a lot of lessons learned from that experience, and K4Health led a documentation effort to document those effective practices and lessons learned from the USAID Zika implementing partners as a whole. So the insights that we documented were not technically or medically specific to Zika, and this was on purpose because we wanted to document lessons that could be looked back on and used to inform the design and implementation of future emergency responses that were unrelated to Zika, and COVID-19 is a great example. So we definitely think that these lessons are very timely and relevant, so thank you for having this discussion today. I highly recommend that you read this report, specifically the 17 lessons learned and effective practices that we pulled out, and I've included the link to this document on the slide. But of course, we don't have time today to go through all of them. But if you go to the next slide, you'll see that I've included a screenshot of the 17 insights, so you can refer back to these slides to get a snapshot. And we didn't only cover knowledge management in these insights, we covered capacity strengthening, collaboration and coordination. On the next slide, you'll see gender and youth issues, integration, knowledge management, and also monitoring, evaluation, and learning. All right, so on to the next slide, KM in emergencies, so thank you. Some initial recommendations for knowledge management in emergencies are to include knowledge management from the start and at various levels. And this includes building out KM mechanisms, processes, and expectations from the beginning. So if partners are meant to collaborate, they need to know, and they need to have the ability to effectively collaborate. And so that means that there need to be systems in place to help them share information and keep one another up to date to strengthen the response and also to reduce duplication of efforts. And when we say at various levels, we mean taking into consideration knowledge management internally within each organization or within each partner, also between the donor and different partners, and then between the implementing partners themselves, and recognizing that these different relationships will likely all require different knowledge management mechanisms. Second, we recommend identifying who will lead knowledge management efforts. So while everyone definitely needs to contribute to KM efforts for it to be successful, one partner does need to be identified as the lead to ensure that KM is implemented in a strategic and systematic way throughout the response. Third, we think this is definitely self-explanatory, but it's also something that can't be overlooked. So we shouldn't assume that we know what people want or need, and we also shouldn't assume that whatever solution is created will fit that need, will meet that need. So we definitely need to take the time to assess knowledge needs at the beginning of a response, throughout the response, and then respond and adapt accordingly to those ever-evolving needs. And then finally on this slide, during an emergency, we all need to be fast, flexible, and responsive. I think we all know this, but we can't let perfect get in the way of good or done when it comes to an emergency. So we need to create something, make it the best that you can given the time that you're working in, get it up, get it published, get feedback on it, and continually build it out. And here I'm specifically referring to knowledge management solutions. All right, so next slide, please. So in addition, partners and those responding to the emergency also need to have multiple mechanisms in place to share technical and programmatic information, also to share best practices and research findings with one another. And this could include recurring phone calls, communities of practice, technical working groups, regional meetings, or virtual knowledge exchange activities. And we usually consider these types of knowledge exchange activities as needing to happen in person. They're definitely most effective in person, but that's obviously not an option for COVID-19. But they can definitely also be done virtually as well. So that's something to consider. And these opportunities for partners to connect need to be reoccurring and not one-off solutions. And then finally, the information that's exchanged during these opportunities or in these meetings needs to be shared and made available more widely. And you can do that through sharing meeting notes or synthesis documents on a shared external platform. Next slide. So that brings me to our next lesson, which is to have one common knowledge sharing platform for external information. And under the Zika response, we created the Zika Communication Network. This was a website that was created based off of the Ebola Communication Network that was developed by the HC3 project. And through collaboration with other Zika partners, we were able to publish over 600 tools, resources, and guidance documents that were created by the different implementing partners and organizations responding to Zika. So that made this website a one-stop shop for Zika prevention and preparedness materials. And it was really the willingness of the Zika implementing partners to collaborate and to share their resources on an external site that made this ZCN successful. And it was also instituted as an expectation from the top down that partners were encouraged to collaborate and to share their resources with this site. And I have included a link to the site at the bottom here. And one last note for this slide is that when there's so much information being published during an emergency, it's really important to reduce cognitive and choice overload by having one central, reliable place to find information, which I think some of the other presenters have noted as well. On the next slide, you'll see another lesson learned, which is for partners, or that partners need to be able to share internal information with each other as well in order to support collaboration and quick decision making. And one example of how to do this is we created a password protected website under the Zika response where partners uploaded their monthly reports. And this allowed partners to see at a glance what others were doing, where they were working, etc. This reduced duplication of effort and supported collaboration. On the next slide, we also found that a key lesson from the Zika response was to create and implement a standard SBC strategy among partners at the beginning. And this is for consistency in messaging among partners. So for example, Breakthrough Action led an SBC working group under the Zika response to connect partners and support collaboration. And through the working group, USAID, Breakthrough Action, and Breakthrough Research led a behavior prioritization process to identify the 7 key behaviors with the greatest potential for Zika prevention that all partners would promote. And the working group also strengthened partner collaboration and served as a place for partners to share preliminary data findings with one another and vet ideas. And I've included links to 2 important documents related to the working group on that slide. And on my last slide, we have some final additional lessons learned. The first is to adapt existing materials and trainings to meet the needs of the current response and to prevent reinventing the wheel and also to save valuable time. Second, we recommend mapping and leveraging existing systems, knowledge, and networks to avoid creating parallel structures. We also recommend conducting rapid and formative research to inform program design and nurture culture sharing among partners. And this is specifically important when it comes to sharing preliminary research findings with others that could serve to inform program design in real time. And a culture of sharing and collaboration really works best when it's implemented and nurtured from a top-down approach. And then finally, we recommend documenting what's learned so that others can apply it. And that's why we were really happy to be able to present today and really excited to hear what the other presenters have to say, because it's really important to learn from past experiences. So with that, I will say thank you, and I look forward to answering any of your questions in the chat. Thank you.
Thank you so much, Anne. And we are collecting questions in the chat box. We'll have a joint question and answer session after the next 2 presentations. So, and we'll also be able to answer during that time. Next, we have David McAfee, who is the CEO at VIAMO, and he'll be talking to us a little bit about some of the digital and remote training opportunities for community health workers that they have been working on.
Terrific. Heather, can you hear me?
Yes, thank you.
Okay, great. Hello, everyone. I'm David McAfee. I'm the CEO of VIAMO, and I'd like to thank the organizers for the opportunity to present some of our work today. So we are a global impact-driven mobile phone technology company, and we specialize in what we call mobile phone engagement. As a company, we believe that information is power, and that access to actionable information can change lives and even save lives. So our mission is to connect individuals and organizations using mobile technology to make better decisions. And more specifically, we help our partners and clients to incorporate the tremendous upside of the mobile phone channel into their operations. We do this because there are now more mobile phones in the world than people. And in many of the countries where we work, it's more likely that households will have access to a phone than even a radio. So next slide, please. So our social enterprise started in Ghana about 7 years ago now, and we've expanded a lot since then. We now have offices in 23 countries in Africa, Asia, and the Caribbean. And when our development sector partners like UNICEF and the World Bank or CARE, Save the Children, and CRS, when they have a community outreach or social and behavior change component to their project, we help them add the mobile phone channel to their campaigns. So instead of just using radio and television to spray out their messages in an untargeted way, we can help them engage with their key target groups via the phones they have in their pockets on the channels they're already using. So we're a proud member of Breakthrough Action, USAID's flagship social and behavior change project led by CCP. And when Breakthrough Action wants to get word out, for instance, about COVID-19, we can quickly add WHO-approved messages to our platform, just like radio and television stations. This means that we have a lot of active users on our platform. In the past 18 months, we've reached about 28 million people. In Rwanda, we have more users than Facebook. To date, about 1.4 million people across 18 countries have listened to 8 million COVID-related messages. We're also reaching the most vulnerable groups at the base of the pyramid. So rural audiences, poor, youth, and women. So next slide, please. We can also use the mobile phone channel for capacity building of frontline knowledge workers, including community health workers. This channel becomes even more important in the era of social distancing, where in-person trainings may be impossible or unsafe. So I'd like to tell you about our recent experience working with the Ministry of Health in Rwanda. Rwanda is special to me. My first job working in development was as PSI's country director in Rwanda just after the genocide. And you may know that the anniversary of the genocide in Rwanda is April 7th. Last year was the 25th anniversary. Each year around the anniversary, the MOH sees a spike in the number of mental health related issues, such as PTSD, depression, and anxiety. They expected an even larger spike last year because of the increased media coverage linked to the 25th anniversary. Johnson & Johnson donated about $250,000 to build the capacity of the community health workers, but there was a challenge. There are about 55,000 community health workers in Rwanda. So the available funds last year were insufficient for an in-person training. So the Ministry of Health in Rwanda hired us to essentially do two things. The first was to adapt or maybe optimize their paper-based curriculum for the mobile phone channel. And really, all this means is we worked side by side with the ministry staff members to create 8 separate 5-minute modules on topics such as introductions to mental health, symptoms of mental disorders such as PTSD, and crucially, where to refer patients for treatment. Now, the MOH was really smart about this training. They organized a pre and post test that we administered by mobile phone in the form of an automated survey. They also added comprehension questions at the end of each module to determine if the CHWs retained the key messages. So Viamo's second task was to push these modules to all 55,000 community health workers in Rwanda at a rate of 2 per week for the 4 weeks leading up to the commemoration. So on the right-hand side of the slide here, you can see the strategy we followed to maximize the number of CHWs who participated in the remote training. So we sent an SMS one day before as a reminder. We followed with an automated voice call with the module itself that included a comprehensive quiz at the end of the module. If CHWs answered incorrectly, they heard the correct answer. They also had the option to re-listen or call back and listen to the module again. And then after the call, we sent an SMS reminder with the key messages. So I'm going to play you just a clip of the English translation of the intro to the first module. It's not a great translation, but I think you'll get the idea. So here's the first 30 seconds.
Greetings. This is an important message from the Ministry of Health regarding mental health training. This training will focus on understanding common mental illness and how to support affected people. The training will last for 4 weeks, during which you will be receiving 2 calls twice a week. Each call will last for less than 5 minutes. Please listen carefully to the entire call and answer the quiz by pressing digits on your phone.
If we could go to the next slide, please. So the results of this large-scale remote training of community health workers were very positive. Just to mention some of the highlights, of the 55,000 community health workers, 93% listened to at least 4 of the modules. And of those who listened, 91% gave the correct answer to the comprehension questions at the end. In terms of the pre and post test results, we saw a range of improvement in knowledge, attitude, and practice from 13% to 25%. I'm personally most pleased that we greatly increased the number of referrals to treatment centers as well. We negotiated successfully with MTN, the local telephone company, to get the airtime costs down to about 1 cent per minute. This means that a 5-minute module push to a community health worker cost about a nickel. The MOH and Johnson & Johnson were so pleased with these results that we're now in negotiations with them to help train community health workers for the next challenge, which of course is the COVID-19 pandemic. We're working with our partners across all development sectors to use this remote training strategy in the era of social distancing, from agricultural extension agents in Tanzania to teachers in Ethiopia to health workers in Madagascar and Mozambique. So the full results of this remote training service will be published soon by our partners at Johnson & Johnson and the MOH. But if we could go to the next slide, maybe I'll leave you with some of the quotes from the participants last year of the community health worker training. My favorite one is the second one here. I have already referred 3 persons with mental illnesses to the health center. I never did that before. Happy to answer any questions that you have. Thank you.
Thank you so much, David. This is, I think, particularly relevant given many of the mental health issues that are occurring now with COVID-19 and, of course, the physical distancing. So thank you so much. We will, as I mentioned, have one more presentation, then we'll have time for some of the questions. So our next presentation will be from EPI-WiN Kidd, who works at Internews, and she is going to talk a little bit about the DSA rumor monitoring experience that they had in Liberia. EPI-WiN, over to you.
Hi, everyone. So as she said, my name is EPI-WiN Kidd. I am currently a media development advisor for Internews in Liberia. But previously, during the Ebola project, I was a humanitarian journalism trainer. So Internews developed its rumor tracking methodology in 2014 in Liberia specifically to address the deadly Ebola outbreak there. Since then, Internews has implemented rumor tracking as a way to address misinformation during humanitarian crises in numerous countries and contexts. So what I wanted to look at today, or what I was asked to look at today, is how did this project start? How did the methodology work? And how might it be applied also, lessons learned for today. So we can move to the next slide. In the spring of 2014, Liberia recorded its first ever case of EVD, so Ebola virus disease. During the Ebola outbreak in West Africa, there was a lot of fear, as what happens when something's new and, let's be honest, really scary. There were a lot of unknowns, especially at the beginning of the outbreak. Even CDC and other specialists started out not knowing a lot of answers, and we're constantly finding out new things, which is, of course, happening now with COVID-19 as well. What happened, knowledge, people immediately began to speculate or to rumor, which in Liberia is referred to as they say. So in other words, they say that blah, blah, blah. They say is the word for rumor, basically. Some of the rumors seem to come completely out of the blue. So you can see on the slide here on the top left-hand corner, it's sort of a saltwater prevention cure. People started phoning each other and saying, if you have, pray over hot salt water and then you bathe in it, you can treat Ebola or you can prevent Ebola. Others could be traced back to specific incidents. So if you look on the right-hand side of the screen, the Ebola zombie photo, that rumor seemed to sort of come from the fact that in many cases, people would be, leaving ill individuals in the street or waiting for them to be picked up, and they would look as though they were dead, they weren't moving. And because of how contagious it is, no one's going to go and check, so they assume that the person has passed away, and then they move again. So suddenly rumors started going around about Ebola zombies, people coming back from the dead. So you could sort of trace some of the rumors. Some of the rumors, we don't know where they start. But in all cases, the fear and the rumor led to panic and often further danger. So in the cases with the zombies, people hid bodies, or in the salt cure, people decided, that they would be cured or could prevent it. So then they didn't need to take other prevention methods. They didn't need to be as safe because they were already cured or, immune. So it's really hard, as we all know, getting correct information to communities that are already geographically remote, as many of them in Liberia are. And in that case, also highly illiterate. But once rumors start circulating, it becomes that much more difficult to get the accurate information across. So this is where our project came in. If you can move to the next slide, please. Our project rationale was that, this is something that was mentioned by some other presenters as well. So in emergencies, people need accurate information, as we all know, in a timely manner in order to make informed decisions that will affect their lives. So if we, as whoever we are, humanitarian responders or aid providers or governments, don't give communities the information they need, they're left to rely on rumors or speculation that either usually give them hope or make sense of a situation. So whether the information sources are trustworthy or not. Unfortunately, as we've probably all seen, this can lead to serious consequences. So the example that I gave about the saltwater cure in the past slide, that led to people running into the ocean. We heard about people, and not being able to swim, but going to try to bathe themselves in the salt water. We heard of people drinking salt water. There were unfortunately a couple of deaths in Nigeria because people were drinking copious amounts of salt water. So, that's one very specific example, but in many cases, rumors in pandemics or in outbreak situations can lead to these serious consequences. So therefore, in Liberia, our goal became, we need to combat these rumors. And in order to do that, we need to identify them and respond with accurate information. If we move to the next slide, this is sort of looking at how we did that. So the DaySay project was a project that was funded by USAID through the HC3 mechanism. And we kind of broke it down into 3 steps. So the first step we decided was to identify and collect the rumors. And we did this in a number of ways. So we did it through SMS systems. So having a code that people could send in a rumor to. We also did it through less kind of technology or more low-tech options. So we worked with local journalists around the country. We developed a network of journalists, and we called them at least once a week. And if they had rumors, we asked them to call us as well, our team, and to identify what were the rumors going around in their communities. And we also worked with Red Cross volunteers, because Red Cross volunteers were all over the country, already in the communities. And we asked those different groups to identify what rumors, what misinformation, or even, as well, questions were kind of being discussed or speculated about in your communities. So we collected all of those rumors, and every week we analyzed them. And how we did that was we sort of grouped the rumors into themes. So some, there might be multiple rumors, but they all sort of were around the topic of contamination possibilities through food, or rumors to do with heat or sunshine affecting the Ebola virus. So we would group them into themes. We would consider possible impacts from each one, like what are the dangers of these rumors, what could be the outcomes. We considered how widespread they were. Are we hearing rumors from a lot of different communities? And then based on our answers to those, we prioritized, okay, which rumors do we need to respond to this week, which could maybe wait till next week? And we went through the prioritized rumors. And in order to do that, we moved to step 2. So we researched a response in order to either confirm, debunk, or clarify details of the rumor. We didn't want to just say, this is wrong or this is correct. The point was to really give accurate information that could provide more context that could get people to understand more about where this may have come from or what people need to understand. And then once we had those responses, and again, part of that was also understanding we don't know, or it's being, looked at, it is an okay answer. We don't have to have a clear answer at this point. We moved to step 3. So that was to share these accurate responses. And we did that in 2 main ways. We first looked at our network of local journalists. So we've, had those weekly phone calls, but we also produced a weekly newsletter for the journalists that they could utilize for their reports to their communities. And we brought them in for monthly workshops. Of course, COVID-19 in-person workshops are not as applicable, but at that point we could bring them in for workshops around Ebola reporting. And then we also produced a weekly newsletter for the humanitarian community. And that was similar to the journalism one, but it was looking at where rumors were coming from, what, and more so that the responders would be able to use the information to respond more accurately in their areas. Next slide. And just, to sort of wrap up on this, the main takeaway lessons that we got from this is that when collecting rumors, always identify ways to do this without giving platform to further amplify or spread the rumor. And note that rumor collectors, including journalists, often need special training in how to do this. Otherwise, they might spread it further. The best way to combat a rumor is not just to say that's wrong, but to respond with accurate information and context and sources for audiences to double check. Always emphasize dates and mention that information can change. We're constantly learning new things. And finally, it's key to, someone else mentioned this already, but key to identify trusted sources and influencers that you could get involved in confirming these messages. So that might be religious leaders, local media personalities, celebrities, people who can influence their communities to try to drive home some of these messages and responses to rumors. So I think my time is up, but if you have any questions, please feel free to send them in the chat group. Thanks.
Thank you so much, Arwen. We do have a couple minutes now for some questions. I know some questions have been answered in the chat box, but looks like there's a question for Anne about, do you have any good examples of common knowledge sharing platforms that we should be using now for COVID-19?
Yes, thank you. I believe I didn't respond in the chat because Catherine said it very well. She included a link to the COVID-19 resources for social and behavior change on the Compass. So the link was sent by Catherine in the chat box, and that is the one that I would definitely recommend at this time. And I'm sure there's others as well.
Thank you so much, Anne. And at the end of this presentation, we do have a slide with resources, and the link to that trending topic that Catherine and Anne have mentioned is there, as well as a couple other places, including the core groups page. So it looks like David has responded to the other questions in the chat box. So unless anyone has a question for Arwen at this time, we will move forward with our other presentations. Okay. So we wanted to spend a couple of minutes to allow you to reflect on the things that you've just heard from these presentations and engage. So for those of you who were here at the beginning, we are using Poll Everywhere to gather some audience responses. And if you were on the URL previously, you should not have to do anything different. But for those who were not yet here, you can navigate to the URL that's here on the screen, pollev.com/JHCCP, and answer this question. What is one thing you want to apply from the presentations to your current work? Excuse me. So it looks like some people want to explore some virtual training further, CHW trainings. Lots of remote provider training, very relevant right now. The chat box that Mindy was mentioning, yep. Yeah, really important communication to providers to reduce that fear. Remote trainings for journalists. Great, we'll give just a couple more minutes for people to think through. Remote trainings is the buzz phrase for today. Great. Okay, so we will move on to some of our final presentations for this section. As I mentioned, we will now be focusing on moving forward. How do we deal with a lot of the challenges that we're facing, and how do we apply some of the lessons learned specifically moving forward as we're addressing COVID-19? So our first presentation will be from Mary DeCoster, who is from Food for the Hungry, and she'll be talking a little bit about adapting materials quickly in emergency settings. So Mary, over to you.
Thank you so much. I'm so delighted to be here. Was happy to be invited, and I was just taking note that pretty much everything I'm planning to cover has been alluded to, at least. So maybe this will serve as sort of a way of kind of synthesizing and pulling things together. Next slide. So a quick overview of what I wanted to cover in my minutes. is what behaviors are we trying to promote? Who is our intended audience? So important to get clear on that. The need to mind the gap and use rapid formative assessments. We'll rapidly adapt similar materials if we have something close to what we need. And how do we shift materials to a new format? And how can we create simple, low-cost materials quickly? Next slide. So one of the things, as many of you are SBC specialists, you know how important it is to get really clear on what your behavior is that you want to promote, and who are we hoping will do what behavior, who should be doing what. Sometimes we go too broad, and it's really important to boil that down to simple, specific, really easy to understand and remember sticky messages, sticky behaviors that we want to promote. And I would suggest in any session, limit to 2 to 3 key behaviors max. And I liked what Corey said about keeping to one set of messages. You want one set of coherent messages. Yeah, next, please. So some of the things you'll be wanting to take a look at, you know, you can use informal or formal rapid formative assessment to find out what behaviors are not getting uptake. You've been promoting, but people aren't taking them up. And there's been a significant discussion about rumors, myths, misconceptions. Really important to be aware of which ones are out there, of course, so you can rapidly address them. And then observed behaviors. I think if you have, you can do some key informant interviews with trusted informants in the communities to find out from them, what are they seeing people doing or not doing? Are people still congregating when they shouldn't be? Are people hand washing? Are people wearing the masks? Or whatever the behaviors of the week are that we're promoting, and what are the barriers that people are aware of to actually practicing the desirable behaviors. Next. So this has been an awesome tool, and I think Heather's going to provide the link for that. In our organization, we rapidly just adapted it a tiny bit and rolled this out into our community to find out our communities where we serve, to find out what's going on. So yeah, kudos to IFRC, UNICEF, and World Health Organization for this awesome rapid assessment tool. Next, please. So I'm sure many of you have experienced rapidly adapting materials, and people have alluded to several examples before. We've also heard about Zika today. So some of you may remember H1N1, the cholera outbreak in Haiti, Ebola. If you have other examples that we haven't mentioned yet, please just type them into the chat box. It'd be interesting to just know how much experience is in the room today. So, for example, on the Haiti cholera outbreak, we had some pretty strong hand washing materials from Mozambique that we did a quick check with the community, and they felt that even the pictures were culturally adequate to use in Haiti, and we could go ahead and just adopt that pretty readily, adding some cholera specific information, but a lot of the module was ready to go. Yeah, same with Ebola. There were some good wash materials that were ready to use. Next slide, please. So people have been talking about transferring materials to new formats, which, yeah, a lot of times we won't be able to work the same way we've been used to working. Originally some of our fields were saying we can't do anything. We can't go to the communities. And I'm like, do you have telephones? Do they have telephones? It's like, yes, they do, by the way. So two-way, for optimal behavior change, you really need two-way communications. We can't just be delivering messaging. We have to be hearing from the intended audience. So some great examples are things like participatory radio programming, where there's a short show and then there's a call-in option. People can share their concerns, barriers, questions. I've seen some really charming videos out of refugee camps, and like Syrian refugees and so forth. If you can show WhatsApp the video to people and then show a quick show that have them watch the video and then discuss by text, SMS, or phone calls. Any of those options where it's a two-way communication is going to be more valuable for uptake. Next slide, please. So as people have mentioned, the situation is that there is new information coming out all of the time. So it's not feasible or desirable to spend too much time or money developing your materials. You want something quick that will do the job. That someone mentioned, don't let the perfect be the enemy of the good. Some of the things we're finding helpful include creating some quick job aids for the healthcare providers, checklists, script for when you're doing phone calls to do either formative research or to share a message, just a script, videos, recordings, and early on, I loved the discussion on trust, and that's so important to bear in mind too, that people, maintaining those relationships that are already in place, and keeping in touch with people for better uptake. Next slide, please. So I developed a handout kind of to go along with this little tip sheet that will be provided somehow afterwards. It's just a little quick 2-pager that goes a lot more in depth than I could in this time allowed, even though I've tried to keep it short. And we've got it in Spanish and French as well. Next slide. Okay, if you could, type into the chat box or just make a note to yourself one idea that's come up in this little super quick session on rapidly adapting and creating SBC materials in the time of COVID-19. Yeah, thank you. I think that's it for me.
Wonderful.
Okay.
Thank you so much, Mary. And if you have questions, feel free to type those into the chat box. And again, we'll have a Q&A session at the end of the next 2 presentations. Thank you, Mary. Our next presentation will be by Carla Sanchez and Catherine Burcham, who are respectively from Save the Children and Johns Hopkins Center for Communication Programs. And they will be talking to us about how we might adapt some of our community engagement activities during this time of physical distancing, and how we can continue to engage with those audiences that need to hear our messages and communicate with us. Over to you, Carla and Catherine.
Yeah, hi, thanks so much, Heather. So this is Catherine Bertram. I'm the Senior Social Behavior Change Advisor with Johns Hopkins Center for Communication Programs, and on the READY initiative. And the OFDA funded READY initiative. So I'm going to be presenting, as Heather mentioned, with my colleague from READY, Carla Sanchez. So she's the Senior Behavior Change Specialist with Save the Children. Just a quick note on READY. Its aim is to augment capacity and coordination, operations, and technical leadership of NGOs and other humanitarian actors to be able to more effectively respond to outbreaks of international concern. So if we can go to the next slide. So READY is facilitating a global risk communication community engagement sub-working group on community engagement and physical distancing in the time of COVID-19. Which resulted in a new joint guidance document with tips for engaging communities in low resource settings when there are movement restrictions. So this document is currently with WHO. It's currently being finalized with layout and some other things. And it should be available Monday or Tuesday. There is a Word version online if you want to look at that before then, and I'll make sure that Heather has that link so she can send that out. But more than 18 different NGO partners contributed to it, and UN agencies and the WHO. And it will continue to be updated periodically. And so the contents include, and if you can just click through some of these. Sure. So what the priorities are of COVID-19 and low resource settings, how we conduct community engagement while physical distancing, how do we collect and address community concerns, rumors, misinformation given movement restrictions, what options exist for engaging communities in settings without cellular or internet coverage, and should we conduct home visits, and if so, how? And then there are some additional examples at the end. So if you can go to the next slide. So basically, what is community engagement about during COVID-19? So we need to think about community engagement in a different way, but also while still maintaining those quality standards of community engagement. So namely, leveraging those local capacities and resources and ensuring participation, inclusion, and two-way communication. But how do you do that when there are lockdowns, when you need physical distancing to halt transmission? So while this document doesn't have all of the answers, it covers some of these main areas, and some of these were already touched on in previous presentations, but how to disseminate information remotely, how, the importance of supporting community-led solutions and addressing those concerns, stigma, rumors, misinformation through two-way platforms. So the next slide, please. So first we can use those, many people had already mentioned the rapid survey. So we can use those rapid survey methods to understand the knowledge and the concerns, perceptions, stigma, behaviors around disease and preventative actions. So especially during COVID-19, it's important to learn the preferences of communication channels and trusted sources of information. And it's important to understand how people are already communicating and already adapting and getting information, and how they perceive risks and barriers to behavior change. And so there's a few examples of rapid assessment tools. One is on here with Save the Children in Somalia using Viamo. We just heard that presentation from Viamo, but there are other tools as well, such as GeoPoll and UReport and RapidPro that are also being leveraged for COVID-19. And in addition, there are some risk communication, community engagement, regional and national coordination mechanisms that are taking this information and that are rapidly analyzing it and putting it on either a dashboard or in like one-pager briefs and disseminating those out to partners on the ground. It's still an area that I think is a little bit challenging, but there have been some efforts in that area. Next slide, please. Of course, we can also provide national and local level contact details for hotlines and services through our community leaders, through traditional media, mass media, print materials, and so on. So we can identify how migrant and transient communities, for example, get information and then provide these hotlines to them as well in the appropriate languages. And hotline information could also be provided for other critical services. So for example, survivors of gender-based violence. And as many of you know, gender-based violence is also increasing in the time of COVID-19. So these are being used in many countries, of course, around the world. I've highlighted a couple of examples here where NGOs supported these developments and where information is not only shared, but collected for data analysis to inform decision-making. And of course, it's another way that we're collecting and responding to rumors and misinformation. Next slide, please. So virtual discussion groups, which are can be composed of local leaders and community representatives, can identify strategies for home care, self-isolation, movement controls, etc., and communication. And these discussion groups in turn can support existing communities, committees or groups. So like women's groups or groups for people with disabilities or care groups. And so we can budget for and provide mobile phones and cellular data and cellular data along with the information on these physical distancing measures and good hygiene, for example. And so there are some examples of discussion groups that are just starting to take place. There's one, I think, happening now with What's Up in Nigeria that was recently created for COVID-19. These groups have been used in the past for Ebola by MSF and other partners. And then, of course, there are also other What's Up groups and online platforms that are being used to foster synergies among the risk communication, community engagement partners, and representatives of vulnerable groups like refugees. So how can we consider leveraging this, for example, for some of the dialogues that Claudia was mentioning earlier around health providers and community members? Next slide, please. So fostering these discussions are important as many of the mitigation measures, such as physical distancing, isolating people in the home who are sick with COVID-19, can be more difficult depending on personal and or household environments. So while we as NGOs can help facilitate some of these solutions, just to say that it's also important to recognize that people can develop effective measures of their own and already are. Which may be more appropriate to the local context. So agencies can also support these community-led initiatives. Next slide, please. So I'll turn it over to Carla, who will spend a few minutes explaining how other approaches can foster these discussions and community connections.
Yep, thanks, Catherine, and hi, everyone. So one of the ways that we're kind of discussing on how to reach and work with communities and some of the technologies that Catherine has mentioned, have been very useful. But there's also kind of harder to reach communities that may not have infrastructure or access to these remote technologies that we're working on. And so we can also go back, take it back to the old school with our interactive community radio. And so we can start by collecting questions, concerns, and feedback from communities in advance of hosting a radio show. And it's a great opportunity also to collect information on rumors and misinformation as well. And then during this radio show, a trusted and influential leader and an expert, together is better, could help to address these and kind of, develop this discussion on the radio show. And then these trusted leaders will continue to help reinforce these positive behaviors and dissuade listeners from practicing high-risk behaviors. I also wanted to add that it's a great opportunity to also create a link or strengthen that link from the community to health services. Next, please. One example of that is UNHCR, which is coordinated with Jamjang FN Radio in South Sudan to disseminate information on COVID-19 prevention. So they're having regular talk shows that bring on board these medical doctors and partners to respond to these questions, and again to squash rumors and to address misconceptions about COVID. And just to add that Save the Children is also kind of discussing right now about how we can further continue community engagement, the CE of RCCE, through community radio, and that could include again engaging these community leaders to help orient communities, and also even to start thinking about how we can develop real high-level basic community action plans over the radio. So those are things happening in the works right now. Next, please. So this has been discussed already, but one way that in Zambia, what they're doing to address rumors and misinformation through community radio is a series of these radio sessions that are Q&A that are addressing myths and information. They're produced through a partnership between Mamas Against Malaria at Scale and the district health management teams. And this is where they discuss harmful ideas around COVID-19 and how this is not just affecting foreigners and how community members are equally at risk. Next, please. Another way, and speaking of rumors and misinformation, there's other platforms that we could use as well, and channels. For example, SMS blasts, short audio and video snippets, and infographic content that can be shared across different messaging platforms such as WhatsApp. And then we have an example from UNICEF's Health Buddy that's built on the Rapid Pro, which is inspired by the COVID information chat box, tackling COVID-19 misinformation and myths in Europe and Central Asia. And it is a really kind of cool multi-channel, multilingual platform that provides COVID-19 updates and also addresses and collects rumors misinformation. Next, please. So going back to non-tech options, if someone in the community has a loudspeaker or megaphone, they could be placed near homes, so that messages could be passed to the community at certain times of the day, especially linking it possibly to, say, in Muslim countries where, there's the regular call to prayer, this could be a great link or opportunity to kind of profit from that. So next, please. An example of this is in Tanzania. UNHCR has supported community health workers and hygiene promoters to raise awareness in camps through public address systems and megaphones. And so this is kind of their way of ensuring that remote and rural, hard to reach communities that are not able to access information through maybe more, high-tech methods can still receive vital information about COVID-19. And this is actually what we're going to be doing for Breakthrough Action in Vietnam. We'll be using these hard to reach communities who are working in rice paddies and other areas with megaphones. Next. Continuing on with this, how to kind of reach these hard to reach communities is to leverage people who are still in the service industry who are still, working and engaging, such as bus and taxi combi drivers, market vendors, and people who work in health facilities who can help to disseminate and share information. And then also in areas of higher literacy, there could be posters placed in the market or, on buses or in these areas where people are still kind of passing or engaging in. And just to say that either these messages and posters could be very simple, not too kind of heavy or text heavy or too kind of overly engaging so as to not create opportunities for gathering. Next, please. And now I'll hand it back over to Catherine.
Yeah, just a few more slides. Thanks so much for that, Carla. So just want to say, in alignment with the national guidelines, it's important to note that home visits can and are still occurring. So especially where vulnerable populations need additional support. So it's not as if these home visits are disappearing now. They are still happening. But these need to happen with strict safety guidance. Can you go to the next slide, please? So for example, the Core Group Polio Project is one of several groups that have outlined guidance for CHWs, for community-based volunteers and other frontline workers that are referenced in the guide we mentioned for how to conduct these home visits safely and to conduct a risk assessment before conducting any home visits. Next slide, please. So finally, and some of this was touched on earlier, but there's been some innovative ways we've been able to conduct remote trainings lately, which are extremely important here. And I just want to maybe highlight one because some of the other mobile-based ones were already mentioned, but I thought this was interesting with Breakthrough Action in Indonesia. The project is using Facebook Live to conduct these trainings for frontline workers and volunteers, with over 7,000 field workers and over 130,000 volunteers using this platform and using and connecting to the platform, where they're even posting photos of some of their activities. So they include these training sessions and skills building sessions. So that is it for us. If you can go to the next slide. Yes, so if you do have any questions, we'd be happy to answer those. Thank you.
Thank you so much, Catherine and Carla. And we do have just one final presentation for today, which is Sarah Collis, who's from UK Med, who will talk to us a little bit about some of the case management and physical distancing implications during COVID-19. Welcome, Sarah.
Hi, everyone. Can you hear me okay? Yeah, great. I will just there's somebody doing work on the roof where I am socially isolating. So I'm sorry if there's some banging in the background. Very nice to meet you all. I'm just going to do a short presentation on looking at how social distancing impacts case management. Next slide, please. So this is me. I just thought I'd give you a bit of a background. This isn't my usual habitat, hanging out with the RCC groups, but I think it's very, very important at this time. So I'm a nurse originally and a health program coordinator now, work with several different NGOs, and I'm trained in the control of infectious disease and worked in several outbreak responses, Sierra Leone and Greece, Sudan, Northern Nigeria, Samoa, Rwanda. I've worked with Ebola, measles, cholera, lots of different diseases where different levels of social distancing have been involved. I wanted to talk to you a little bit about what I think are sorry, next slide, please. The sort of lessons that I think are relevant still in the COVID-19 outbreak. And I kind of put it down into three different questions that I'll hope to answer very shortly. For me, sort of case management is quite simple. In many ways, it's quite scientific. You isolate cases, you clinically manage them, but it's all of the outside factors that can make your case management strategy either successful or not. And then it gets quite complex and you need to know the bigger picture. So I'm going to talk about how can social distancing impact health services, what can we learn from previous outbreaks, and how is COVID-19 similar and how is it different? Next slide, please. So I thought it's especially important to talk about what do we mean by social distancing. When I said this to one of my colleagues, they said, well, it completely depends on who you are as to how social distancing affects you. And I've started to look at it mainly in three different ways, which is how does it affect the individual? How does it affect multiple people? And then what about those where social distancing is not an option? So mostly in the places that I work, refugee and IDP camps, slums, and some of which has been talked about already in the previous presentations. So it's massively contextual, and social distancing, whilst it can prevent infections, which is what obviously we're working towards, it can have these unintended consequences on other health issues that are just as important, and that's what I'm going to talk about now. Next slide, please. So I worked in the 2014 to 2016 Ebola outbreak in West Africa. I've since worked on preparedness efforts in Rwanda. So it's been really great for me because I've been able to see how things have improved, and things that perhaps we're still not looking at. So how does social distancing impact services? So the obvious one, and the one that we see in all of the pictures, is PPE, so personal protective equipment. You need considerable amounts of it. You're not able to see patients without it, so that's sometimes stopping the volume of patients you can see. There's not enough to go around. It's incredibly scary for your patients. It makes people not seek care. Ebola treatment centres are also, they require a high level of human resources, and often these staff are taken away from core services in the main hospitals, but also in, we had sort of hygienists working within the treatment centres that were school teachers. So there's a lot of disruption of these key services, especially for things like nutrition, sexual and reproductive health, and often closure of these services and fear to come to them. There's a lot of civil unrest, and I expect that we will have a lot more during the COVID outbreak. Lack of transparency in the response and mass panic, sometimes misleading media and information. One thing that I observed quite a lot during the Ebola outbreak, I'm sorry for the banging, was that the engagement the decision whether to do something for the greater good versus human rights of individuals. And as a result of that, we kind of got to this place where we were looking at a one-size-fits-all approach and not looking at individual needs. We also had to look a lot at staff well-being. Staff were taking tremendous risks. They're not able to live with their families, sometimes not being paid. Also, healthcare providers were already undervalued, and this was stopping people from coming to work often. So really putting pressure on the success of your case management and having the available treatment for people. Also staff getting sick, and the way that we were addressing that as managers and supervisors, and often resulting in a loss of your workforce. Safe burial, people were not being allowed to see their loved ones, not being able to attend funerals, a lot of implications for psychosocial for people ongoing and still affecting people now from that traumatic event. Indirect effects on other diseases were documented. I worked within a research group that looked at all of the data of what cases they would have expected in hospitals during the Ebola outbreak, and I believe more evidence has emerged since then that a lot of these services were not kept going, or people were scared to come to them, and there wasn't enough messaging around maintaining immunization, for example, malnutrition programs, and lots of decrease in hospital admissions for under fives especially. Next slide, please. So what can we learn from these lessons of the previous outbreak? So I just wanted to touch on some things that I have seen improve in the Ebola outbreak in DRC, but also that we're carrying into COVID-19 now. The use of design and innovation to use less PPE. So the benefit of not using as much PPE is some of it obvious and some of it more nuanced. Things like visors that can keep staff safe, but also create a level of connection between the patients, that you can see someone's face. Also creating treatment centres where everybody's not bunched in together and everybody needs to wear PPE going inside, and being clever with the way that you structure your walkways, for example, so that people can see who's treating them from outside, and then you also don't have as much risk to your staff. I think I've started to see sort of focus on the protection programming and sexual reproductive health services come back, separate services for pregnant women, better transparency, sort of inviting community health workers into the treatment centres. So how is COVID-19 different? So we know it's a pandemic, and this time around it started in middle, higher income countries. I think engaging tech companies have been slightly easier in some ways because of the size of the outbreak. What is transferable? I think anti-stigma interventions, when you're discharging people back into communities. We're beginning to see better tailored interventions. I think we're starting to look at focusing on business continuity from the beginning and understanding that the indirect impacts of outbreaks can be just as bad. And then I've just left you with a few examples of different innovations that we've been working out for social distancing. Sorry, for the next slide. just to finish up, we've already talked about different technologies and WhatsApp as a platform. The top picture is just showing a design we've been working on in the UK to try and use less PPE and try and make the experience within the isolation centre to be more personable. There's a visor I talked about. Below is a transfer hatch, which helps you to transfer things without wearing PPE and makes your healthcare workers feel safer. And on the right is what's called the cube, where you can treat a patient, but also it's not a very good picture because everybody's sort of staring in, but it just allows people who are being treated to feel that they're around people and not suits. So sorry, I think I probably ran over then, and I'm sorry about all of the banging. Very happy to answer any questions, and hope that was a good overview of some of the things that are going on in case management and some of the things that we're bringing into coronavirus that we've learned from other large outbreaks. Thank you.
Thank you so much, Sarah. That's wonderful. It looks like Mary has a question for you. She's asking, I've been trying to find something on safe community burial where there's little or no infrastructure for that. What are current recommendations or a good place to look for that info?
Yeah, sure, I can answer that. So I think just as a general point, because this outbreak started in higher income countries, where I think a lot of the guidelines came out assuming that there would be the resources to do these things. There are safe burial guidelines, and they are with WHO. There's also, I think the Interagency Standing Committee are working on some burial guidelines, but I can, maybe if I take Mary's contact detail, I can direct to some of these resources, or I can post them in the chat now, if that's helpful.
That would be great.
That would be great, yeah.
Thank you. And we are almost out of time today. I really want to thank our presenters for their time today. We all know that things are very busy right now with COVID-19 response efforts. So thank you all for joining and for providing all of this very interesting context for us. I just want to finish by noting that Breakthrough Action has created a guidance document on social and behavior change for family planning during COVID-19, which is likely really relevant for all of us. We don't have time to go through the details, but again, at the end of this presentation, we do have some resources, which this guidance document is also included in those resources. We would love to have some time to spend chatting with everybody about some of the implications of COVID-19 on our RMNCH presentations. RMNCH work that we're doing right now. And so we would love to move this conversation to Springboard to talk about some of the challenges that we're facing and some of the things that are working for us. And so I think, as many of you know and are already members, we do have a Springboard group for our SBC for Service Delivery members. And so we will send out a link to that and some of the questions that we would like to discuss there. So we will link to all of these at the end here. We have these resources, some of which have been mentioned already today, including the Compass Trending Topics, both in English and French, and also Core Group's COVID-19 Resource Library. The one that I just mentioned that Breakthrough Action has just put out is the Guidance on SBC for Family Planning during COVID-19. The one that Mary mentioned is the Rapid Assessment Tool from Claudia's presentation, the Emergency Helix, and then Breakthrough Action has also put out a rumor tracking technical brief, and we will also send along the tip sheet that Mary was so kind to develop. So we do have several of these resources available for you, and we will send out more details about continuing our conversation on Springboard. Thank you all so much for joining, and we hope you have a great day.